Hi everyone, you're watching the final in the series of SIT Certificate in Health Sciences. So far we've been looking at the different systems within the human body, but today we're looking more towards abnormalities, things that can go wrong. So we're going to look at one in the nervous system, which is epilepsy. How are you today, Craig?
I'm good, thank you.
So tell us a wee bit about epilepsy.
Well, we have to remember that epilepsy affects the brain. And if we think of the brain as a giant interconnected electrical system, and everything usually in the electrical system goes along, flowing in all the directions it needs to, with no real problems. And unfortunately, in the case of epilepsy, it's a little bit like a short circuit in our electrical system of the brain.
Electrical system is in like the nervous system?
Yeah, that's essentially what your nervous system is.
Right.
It's an electrical system.
So what can cause epilepsy?
Oh, there are a number of different causes of epilepsy. In babies, for example, if babies get too hot, they can suffer seizures. We have a typical one of head injuries, so kids falling off bikes. That's why we have the helmet law. Motor accidents, drug use, excessive alcohol use. There is some hereditary component, it can be passed on. There are a number of different ones.
So it's usually triggered by something?
It's usually triggered by something, yeah. But when it starts, it can be very, very different. You have some people who have had no head injury, no seizures ever, and suddenly it happens.
So what part of the brain does it affect?
Well, it depends on the type of epilepsy. Our brain, as we can see here, has different regions that control different parts of our body. For example, we have this light blue strip down here is your motor cortex, and that controls all your movements, your handwriting and singing and dancing and those kinds of things. We have behind that we have a little section that controls all our senses, taste, smell and so on. Right at the very back of our head, on the brain there, that's where all our vision is controlled there. And on the side of our brain here we have hearing. So depending where an injury might have occurred or where there's a small problem in the electrical system of the brain, we get different types of epilepsy. And we see here, for example, some people get what are called partial seizures, affect only a small area of the brain and can result in repetitive movements, hallucinations and so on, depending. So if someone has got a problem in the brain, electrical problem, for example, in the visual area, their epileptic seizures may be seeing things.
Right.
Some people who have one in the motor cortex, for example, might just make repetitive movements like picking at their clothing or blinking a lot or licking their lips.
So it's actually a lot broader than just having seizures, like as in fits on the ground.
That's right, and that's what we typically think of when we think of epilepsy, these grand mal or whole body seizures. And these are our generalised seizures. And what that does, it affects the whole brain.
Okay. And
it might start somewhere and it gradually spreads its way around the brain, affecting all the different systems. And people who have our generalised seizures tend to know that something's coming on. They have a premonition or they just a smell, a taste, a feeling, and they know that they may be in for a generalised seizure.
So something usually trigger it off?
There are lots of things that can trigger it off. Flashing lights, for some people it can be a smell, those kinds of things. And what we tend to find there is it will start in one part of the brain and it just spreads its way across. Right. So we get our full body seizure where the falling on the ground, grunting, our jerking motions. Sometimes you have loss of bladder control, loss of bowel control. There is another type of generalised seizure which we call absence seizures, and quite often see these in children, for example. And what that is, they just tune out. Suddenly they're there, suddenly they're not there. And some kids can have 50 to 100 of these seizures a day where they're just tuning in and then they just bang, tune out, tune back in, and they've got no idea that it happened. It's like losing little wee chunks of your day. And if you can imagine being a child who has absence seizures sitting in a classroom, having, let's say, 20 or 30 of these seizures a day, how much learning you can be missing out on.
Absolutely. Is that something that's usually picked up pretty early on?
It can be picked up fairly early on. Sometimes it's seen as this child daydreams a lot, or doesn't seem to be paying attention a lot. Could be this form of epileptic, of seizures.
Gee. So how can you control epilepsy?
There are a range of drugs that are used, different doses depending on the person, lots of different types of drugs that are used to help control it.
Great. And I suppose it's really helpful just to be aware of it, so if anyone around you is having a seizure or something, we can know what to do to help.
Oh, very important, especially with these generalised seizures. There are a lot of things that people say you should do. Like, for example, you should try and clear their tongue out of their mouth so they don't swallow their tongue. Well, if you go putting your finger in, chances are they're going to bite your finger off.
Right, okay.
Because it's big muscular contractions going on. The general rule of thumb for somebody having a generalised seizure is just clear the area of things like sharp objects, chairs, tables, desks, things like that. Try and put something underneath their head, a rolled up jersey, a coat, so their head doesn't bang on the ground, and then just let them have their seizure. When the seizure's over, just make sure that put them in the recovery position, so in case they're sick they don't inhale their own vomit, and then just let them come out of it nice and slowly.
Great. Thank you, Craig. I've learnt a lot from this today.
That's good.
Thanks. We're now going to take a look at a disorder that affects the skin, which is melanoma. Janice, so is melanoma a cancer of the skin?
Yes, it is. It's one of the 3 skin cancers.
Right, and what are the other 2 then?
The other 2 are basal cell carcinoma and squamous cell carcinoma.
Gee, you wouldn't want to try saying those too fast, would you?
No, you wouldn't actually.
Great, so does it just affect the skin?
Yes, melanoma. There are over 100 different kinds of cancer, but melanoma simply occurs on the skin.
Right, and does it sort of travel?
It begins as a mole or a freckle, and like all cancers, as they can develop into secondaries. Do you want to have a look at the pictures and see how that happens?
That would be really good.
This here is an abnormal cell in the skin, and the thing that makes it abnormal is the rate at which it develops. So it multiplies out of control, and you see a tumour beginning to form. And cancer cells make such bad neighbours, they push into other areas and may push into the bloodstream.
Right.
And this is an indication. Here you have a cell, the tumour, pushing into the bloodstream, moving around and clumping, blocking at a point and then pushing out of the bloodstream and developing a secondary cancer. So that's how all cancers, including melanomas, move.
Ooh. So it just starts off as a freckle or a mole, you were
yes, it
saying?
does. Yes.
Does it usually always start off like that?
Yes, yes. It's important that you're aware of any changes in any freckles or moles in the skin.
Right. So what's a normal looking mole or freckle look like then?
Okay, so we have a little cartoon series over here, and a normal or a perfect mole, if you like, is smooth and it is round and it's regular in colour as well. And then there are different changes that can happen to that mole that you should check out. It might be that it grows larger or changes in shape.
Right.
It might rise in height, and that's a particular problem with melanoma. The depth of the melanoma is quite relevant. And a new mole might suddenly appear, or it might change colour quite dramatically. Now, if any of these things happen, you should check with a doctor sooner rather than later.
Right, so these are all signs that something could be wrong.
Yes, and the important thing is melanoma does move quickly, so it's not, if you're concerned, get to your doctor and get it checked.
Okay, and so if there was something wrong and you got it checked out, how easy is it to cut it out?
Well, it is a surgical procedure to remove it, but it's not difficult, especially if, as I said before, it's comparatively thin.
Right, and can you usually, by just taking the mole off, will that usually get rid of the problem?
Yes, it will. The doctors will normally send that away to be biopsied just to check, in fact, that it was a melanoma, because sometimes there are so many different forms and colours and shapes that sometimes it's hard for them to tell.
Right. So I guess it's better just to check in the first instance, isn't it?
Yes, it's the safe thing to do.
So what sort of people get skin cancers?
Well, anybody, though it particularly tends to affect people who have paler skins, and those most at risk are the blonde or redhead Celtic type skins. They would have blue eyes and very fair skin that never tans and might freckle. So they're most at risk. And the skin colours grade through to very dark skin, dark brown skin with brown eyes and dark hair, and they're less likely to develop skin cancers.
Right, so we're more in the danger zone, it looks like.
Well, not only that, but a lot of our settlers in Southland do come, they are Celtic peoples, so we have a lot of that kind of ancestry in Southland. So yeah, we are at risk.
Right, so is it usually just from the sun?
Yes, that is the leading risk factor for melanoma, especially severe sunburn in childhood and adolescence. Those are the principal reasons we believe why melanomas develop later in life.
Right, and is there a usual sort of age bracket which you'll catch melanoma usually?
No, melanoma and skin cancer is the most common cancer between 20 and 40, and all cancer risk increases as we age, so obviously the risks for all cancers rise.
Right.
For the elderly.
And what about in our part of the world? Have we got a higher chance of catching melanoma because of the ozone hole?
Yes, we have. There's no doubt about that. The ozone hole has thinned and probably diminished in New Zealand by about 10%. And the figures are that we get 7% more ultraviolet radiation in the southern hemisphere than we do in comparable latitudes in the northern hemisphere, and that does make a big difference.
It sure does, doesn't it? So what can we do to reduce our risks of catching melanomas?
Okay, well, I guess the simplest thing to say is don't get sunburnt. I mean, we're very careful if we're working in the kitchen not to be burned, and yet many people just accept sunburn, which is still a burn, as a natural consequence of living, really. So I think that message of don't burn and take whatever steps you need to avoid that. So that is the slip, slop, slap and wrap message. The slip on a hat and the shirt, the sunscreen and sunglasses, and also remember to seek shade when you're outdoors. That's the package of things to do.
And it's always been ingrained into us, hasn't it, Liz?
It has, and I think that's really important. And I think the other thing we need to remember is that ultraviolet, which is what causes the sunburn, doesn't just travel directly from the sun. It bounces around through the ozone layer. It will bounce off hard surfaces. So even if we think we're comparatively protected, sun and water are really bad surfaces for it to bounce off too. So often people get sunburnt skin.
Right. And what about ultraviolet rays? Is it only in summertime, or do we have to be careful all year round?
We say particularly between 11 o'clock in the morning and 4 o'clock in the afternoon during the daylight saving months. That's the time when the risk is greatest, and when the UV index, the ultraviolet index, the measure, the scientific measure we use, if that's 6 and above, then we do need to seek protection.
Great. Lovely. Thank you for your time, Janice.
You're welcome.
Liz, and diabetes is another disorder of the human body, but what exactly is diabetes?
Diabetes occurs when, for one reason or another, the body can't make enough insulin to utilise the foods that people are eating. Now, insulin's a hormone that is designed to lower blood glucose, and it is manufactured in the pancreas, and the pancreas is tucked in behind our tummies and has a multitude of functions, but making insulin is one of those functions.
So why can it sometimes not make insulin?
Depends on which type of diabetes we're actually looking at.
How many different types are there?
There are two main types. Type 1, where for one reason or another the person's body has actually destroyed their insulin-making cells. And they don't know why. But it's a bit like people can identify often with heart and kidney transplants, and they know that the body may reject that foreign substance that's been put in it. And for some reason, for these people with type 1 diabetes, their body gets confused and thinks their insulin-making cells are a foreign substance and actually destroys them. So they cannot make the insulin that their body needs.
Right, and what about the second type?
But in type 2 diabetes, it's more what I call a wear and tear, and that we might start off with 100% of insulin-making cells, but for various reasons, people wear them out.
So is the first type of diabetes, is it actually called type 1 diabetes?
Yes, it's called type 1 diabetes.
Are people usually born with that?
They may be born with the risk of developing or the genetic susceptibility to it, but having that susceptibility doesn't mean that they will actually get the diabetes. They feel that something else, perhaps a virus, may trigger that susceptibility in that person.
Oh, really? And what about the second type, because you're saying it's wear and tear, does that usually happen later in age?
Well, until more recent years, they used to call it the old age diabetes, but of course it is happening far more now, even in adolescents and much younger age groups.
So what is it like to live with diabetes?
Probably if you ask the person with diabetes, they'd say it's actually quite difficult because it's quite demanding. People with type 1 and diabetes in particular, I mean, they have to take insulin injections every day and they would die without that insulin.
Gee.
So some of them will be taking 4, sometimes even 5 injections a day.
Wow.
So it's quite demanding, and of course to see how their diabetes is going and how they're managing, they need to do blood glucose monitoring. And once again, they could be doing that 4 or 5 times a day.
Gee, it's a lot, isn't it? It's huge.
Mm.
And the insulin injections, is it usually something they do themselves?
Yes, yes. Apart from really young children, then obviously the mother might or father may do that for them. But the majority of people are administering their own medications. Yeah.
Gee. So what part of the body does diabetes affect then?
Well, unfortunately, if it's not looked after, it can affect any part of the body. It can damage any blood vessel or nerve throughout the body. And when you look at the distribution of nerves and blood vessels, of course, they go from the top of our head to the tip of our toes. So it is a concern. It's not something that happens immediately. It's one of these things that can develop over time.
Right.
And the glucose in the bloodstream, if they have excessive glucose in the bloodstream, which is what occurs with diabetes when we're short of insulin, then that can damage the lining of those blood vessels, and it can also damage the nerves.
So it can actually get quite a bit worse.
Yes, yeah. And that's why we focus so much on trying to get people to look after themselves today and tomorrow and next week, so that in 5, 10, 15 years, that person is still healthy and having a good quality of life.
Right. And what sort of person is usually affected by diabetes? Is there like a certain category of people that, you know, risk factors that you can...
Yes, when we look at type 2 diabetes, and that's the one where you're hearing so much more about that and the association with type 2 diabetes and obesity, because as a nation, we're getting more and more problems with weight and people perhaps not being as active as they should be. And that increases the demand on the body for insulin. And that's where that wear and tear sort of comes in, and people wear out their insulin-making cells. And they say for every 1% increase in obesity, we're going to get another 2,300 people with diabetes.
That's incredible. So how many people in New Zealand would suffer diabetes?
They predict that we would have about 140,000 by the year 2011. But I was reading recently where they've actually underestimated those numbers by about at least 35,000.
Well, that's incredible, isn't it? It's huge numbers.
Yes, massive numbers. And unless we can do things to change people's lifestyle and reduce the obesity rate and get people active and getting some healthier eating habits again, then I hate to think really what will happen in the future.
Gee. So if you have diabetes, it's something that you'll have for the rest of your life?
Yes, yes. And that's why I say we're often with the miserable people. We tell people they've got a condition, and then we very kindly tell them that we can't cure it.
Right.
And we very, very kindly tell them it belongs to them, and they can only ever have the level of control of their diabetes that they wish to put the work in to achieve.
What are some of the symptoms of someone who may be suffering from diabetes?
Well, if we look at type 1 diabetes, they'll often present with what's termed the classic signs and symptoms, where they'll be thirsty, they'll be going to the loo a lot, they'll be tired because the body's not getting the fuel it needs to keep them going. And a lot of those young ones will lose weight, and they can lose weight quite dramatically, despite perhaps even eating more, because the body's saying, I'm hungry,
Right.
feed me, but they haven't got the insulin to utilise that food. But a lot of the older people who get type 2 diabetes don't have any symptoms at all. It's very difficult for them. It's often only the numbers, or they're found by accident. They come into hospital for another reason, or the doctor does a routine blood glucose as part of perhaps another blood test and find that they have got abnormal sugars.
Thank you very much for your time, Liz. That's really interesting. I've learned a lot. Another condition which affects many New Zealanders is in fact arthritis. Robin, can you explain to us what arthritis is?
Certainly. Arthritis is the destruction of cartilage and bone through wear and tear, or there's actually quite a few reasons really, but if I just look at the posters here, this is a normal joint where the cartilage is nice and firm, and that gives you nice movement. And osteoarthritis here, where the cartilage is being destroyed and you end up with no cartilage and bone on bone, and that creates a lot of pain. And arthritis is actually one of the leading causes of disability in New Zealand, with over 500,000 New Zealanders affected. So in our Southland area we have sort of over 15,000 people that are affected by some form of arthritis.
Wow, that's huge.
Yeah.
So can it affect all the different joints?
It can affect every joint in the body, and also it's no discriminator of age. It can affect children to elderly, so there's a wide range of people affected, and a wide range of arthritis as well, arthritic conditions. In fact, there's over 120 types of arthritis, so it's a massive area.
120 different types, that's huge. What are the main ones?
The main ones are the osteoarthritis that you see here, rheumatoid arthritis, gout. There's also a lot of people with a condition, older people usually, with polymyalgia rheumatica. There's lupus, there's juvenile arthritis with many conditions. But the main ones we see most of is the osteoarthritis, the rheumatoid arthritis.
And what are the main differences between the two?
Well, with osteoarthritis you can have perhaps just one or two joints or a hip joint affected. But with rheumatoid arthritis, it's a whole system condition. It's everything from, or every joint can be affected to a few joints affected, but it's a condition that makes people feel generally unwell, like they have a flu ongoing. And in rare cases too, their organs can be affected as well. So it's sort of a very different kind of arthritis.
Right, so that usually affects all of the body.
It can. Again, there's sort of like a line where some people will have a few joints affected by arthritis, especially the rheumatoid, and they may just have it be bothered from time to time. At the end of that line, there's people that their lives are completely altered by rheumatoid arthritis. They're severely ill. Right. So you can be anywhere along that line. So it's a very individual thing. Each person we see is actually, we treat as an individual.
Right. And of course we know arthritis is quite a painful condition. What does it feel like to have arthritis?
Well, I have people tell me virtually it's like having glass in their bones. It's just a pain that's always there, and that's how they relate it to me, is that there's broken glass in their bones when they're trying to walk.
Right.
And it's just constant.
Ooh.
So it's a nasty condition for a lot of people.
Yeah, and as we're looking at the posters, it's sort of the cartilage disappearing. So can that affect elderly people especially a lot?
Well, it can affect people that in their latter years, just for the fact I think that perhaps we are getting older and things perhaps break down. But it can affect people at all ages really, especially if someone's had a sporting injury or an accident, or they've been born with a genetic condition that maybe their hips were out of line a little bit. So it really does affect everyone, but it's more common in perhaps over the 65 age group.
So what could you do for arthritis?
There's lots you can do for arthritis, yeah. Apart from having good relationship with your GP and orthopaedic surgeons or rheumatologist, is understanding that the best thing for arthritis is mobility, the right kind of exercise, the right kind of movement. So the best thing is to keep moving, but it needs to be paced and the right kind of exercise. So that's where we come in. Sometimes we talk one-to-one and sort of help people plan what their attack's going to be to manage this arthritis.
Right. Is there any medication that can be taken as well?
Yeah, lots of medications too, and that's probably best talked with their GP or specialist because they know the individual person and what suits them. But there's anti-inflammatories or there's disease-modifying drugs that are sort of further up the line, and there's your normal painkillers that are effective if taken correctly. So, but we do recommend people talk to their doctor or pharmacist about pain medication.
Right.
There's also relaxation techniques that we encourage as well to help with the stress and things, and that can reduce pain as well. Plus exercise reduces pain.
Are some people more at risk of getting arthritis than others?
Well, possibly. I mean, they're doing research all the time, and in some cases I think they have found that there is a family link to some kinds of arthritis, but that doesn't necessarily mean that if your parent has arthritis that you're going to have it. So it's a bit of a mystery really, but I know they're doing research all the time, and some types of arthritis there is a definite link and some there isn't, so it's still quite a big field to look into really.
Right. If you have arthritis, is there any way you can get rid of it, or is it just something that you can manage?
Well, I think well managed, and lots of things can come into place, including even joint replacement for people that have been severely affected. But I've seen some miraculous things happen after people have got a new joint and they're doing their exercises and they sort of regain control over their life and get back to things that they once enjoyed. But really it is the exercise and the keeping moving that can keep you active out there in the community. So that's what we promote.
And if someone thought perhaps they do have stiffness in joints and would like to get it checked out, where could they go to?
The best place is their GP, yeah. First protocol, I think.
Great. Thank you very much for your time, Robin.
You're welcome.
Thank you for watching our education program for the Certificate in Health Sciences. If you'd like more information about this course or any other offered by Sit to Learn, you can contact the team at SIT on 0800 Sit to Learn. Bye for now.